So welcome. I'm so excited to have you all here today. We're going to be speaking with Dr. Bat-Sheva Maslow about egg freezing. I'm Ilana Frank. I'm the CEO and founder of Jewish Fertility Foundation. Like many of us in this space, it is very personal. My three boys, ages 8, 7, and 1, were born via different types of fertility treatments, 2 of whom were born in Israel, and my baby was born via embryo donation. So I feel very fortunate to be able to be working with Jewish Fertility Foundation. Who are we? What do we do? We offer 3 main functions to our clients. One is financial assistance by way of grants, up to $15,000. We are community-based. Right now we're in Atlanta and Cincinnati, but our goal is to be expanding to 15 cities in the next 5 years. In addition to money, which is really, really important, we also offer emotional support and educational trainings. We do traditional support groups, again, community-based, even though everything is virtual today because of COVID. And we also offer a fertility buddies program where we match up veterans of infertility with people going through it today. And lastly, our educational trainings, like we're talking about today, is we offer our community things that they want to know. So one of the big questions we get is about egg freezing. So we're going to dive a little bit deeper today. And we really want to get to know you, Dr. Maslow. Who are you? Where are you from? What are you doing with us today?
Sure. So thank you for having me. This is really exciting. And I'm really thrilled to be here with you guys and be a part of your organization and the great things that you are doing. My name is Bat-Sheva Maslow. I'm a reproductive endocrinologist, aka fertility specialist here in New York City. I work in a practice in Midtown Manhattan. It's called Extend Fertility. It was really the first practice in the United States and truthfully the world that was developed with a special pathway dedicated to women who were interested in fertility preservation, who wanted to be proactive about learning about their fertility. We've since expanded to really offer the full gamut of fertility services. So we have sort of a egg freezing pathway and then a more traditional fertility pathway. And so I get to really have the best of both worlds. But our egg freezing program was founded primarily on the roles of education. And one of the things that really drove me to be a part of this is recognizing that women of our generation, mine and yours, and women younger than us who are sort of growing up into this world where we are able to do so many things, right? We're told, you can be the CEO and a mom and you can do pretty much anything. There's no limit to what you are potentially capable of. But if you want all of those things, and many of us do, it comes with really a recognition and understanding that what are sort of the natural biological processes that happen related to fertility? What are the limitations? What can it do? What can't it do? What can we predict? What we can't predict? There's so little education out there. And so that was really, passionate about being able to educate women so that they can make informed decisions about their lives. And not just sort of assume everything is fine or assume everything is not fine, or kind of live in the dark or live under this umbrella of this very paternalistic attitude of oh, we shouldn't talk to women about this because it's gonna just worry them. It's really too much. It's too complicated. Starting from the premise of this is complicated. It's nuanced. It's not straightforward. It's not the same for everyone. But we can have adult conversation and educated conversation and give people the tools to make decisions about their lives based on actual data.
Love it. I appreciate that. So let's start in the very beginning. What is egg freezing?
Perfect. So egg freezing is the process of literally freezing or preserving eggs. And the reason it's even a thing is because we've learned over the years that female fertility declines with age, primarily as a result of errors that accumulate in the DNA of the egg. So the egg is a single cell. It's actually the largest single cell in the human body. It's actually quite fascinating when you sort of get into the nitty-gritty biology of it. Over time, women are born with all the eggs we'll ever have. We lose our eggs over time, and eventually when we run out of eggs, we go into menopause. But the other thing that happens is that those eggs start to develop abnormalities where they have either too many or too few chromosomes. And these abnormal eggs will often not work. And so that's typically what's responsible for the fact that as women get older, just naturally, on average, the length of time that it takes to conceive might increase. The number of months that it takes to conceive will increase because really we just get one egg each month. And if that's a good egg, then that's a month in which we can conceive. But if that's not a good egg, then that's typically a month in which we wouldn't conceive. And so the premise of egg freezing is to be able to preserve a group of eggs that has a higher proportion of healthy eggs than you might have sometime in the future. So that if you ever needed infertility treatments, and some people may never need infertility treatments, may not be with a first child, maybe it will be with a second child or a third. But the infertility treatments, especially IVF, the success rates are directly tied to the age of the eggs that are being used. So if somebody is 40, but they get to use their 34-year-old eggs, then it's as if they're 34 at the time they're doing their IVF, and they've more than doubled, actually almost tripled their chances of success.
So let's say that I end up freezing my eggs when I'm 30 years old because I am informed and I understand, and I go on to have a partner later on where I want to have a child. Am I ruining my fertility chances to try naturally?
That's a great question. I get that all the time, and thankfully, no.
Okay.
The way it works is kind of get into the nitty gritty is that every month there's a group of eggs, a cohort of eggs that become available, and they come to the surface when we do, when we do ultrasounds of women's ovaries. You see all these little black dots, or we call them follicles. They're little bubbles. They contain immature eggs. In the natural menstrual cycle, the brain will tell the ovary to select one of those eggs to grow. And that's the one that's going to grow, mature, release for ovulation, and be available for pregnancy. The remainder of those eggs that could have been chosen but weren't essentially sort of self-destruct, and the body just discards them, and then kind of new ones come. And that's how we plow through our egg supply, right? We're born with millions of eggs, where there's so many of them that just sort of come to the surface and get lost, and come to the surface and get lost. When you do fertility treatments like egg freezing or IVF, the truth is it's the same thing. The medications that we use are just higher amounts of the same hormone the brain uses to tell the ovary to grow one egg. And instead, what we try to do is grow as many of those available eggs. And what we're preserving are really the eggs that you otherwise would have lost that month. So women who do this process don't go into menopause earlier. Not like if I freeze 12 eggs, you go into menopause a year earlier, like we're stealing from the future eggs. Thankfully, that doesn't happen. And it really doesn't affect fertility in any way. So unfortunately, there are some women who are sort of destined to experience infertility, but it's not related to whether or not they did a process like this.
Okay, so walk me through it. So how old should I be to consider coming to you to do egg freezing? And then walk me through the process from meeting you till my eggs are in the freezer somewhere.
Sure. So, lots of people ask me what's like the perfect age to freeze your eggs. And the truth is there really is no perfect age. Sometimes I say like now is always better than later. But not necessarily, it really is very dependent on an individual's biology, their goals, right? Somebody who's not sure she wants to have children, but doesn't want to be in a circumstance where that sort of option gets taken away from her, has a different conversation than the person who's like, I want to have 6 kids, but I don't have a partner yet, right? That's a different conversation, and the timing may be different. But generally, egg freezing is going to be the most efficient and effective in like the early 30s. 30 to 35 is going to give people sort of the most options. That does not mean that if you're over 35, you can't do it. Actually, I have lots and lots of patients. The average age of patients who come to see me is about 36.
Okay. Do you think that that's different from New York age versus nationally? Maybe you don't know that, but
I mean, I think we're kind of culling together probably the most data of anyone else about egg freezing because we have the volume right now. So we've done like over 3,000 egg freezing cycles. I just published like 3 papers on egg freezing, maybe more than anywhere else. But so I think ours is probably reflective of that. But actually, just to be perfectly honest, I'm presenting at, now it's virtual, but the upcoming ASRM conference, the American Society for Reproductive Medicine. The data that I'm presenting is actually for women who are freezing their eggs ages 40 to 45, which is not the typical. And, there are a lot of limitations there, but for the right patient under the right circumstances with the right counseling, it's something that can be considered for sure.
Okay.
Okay, so let's say, a woman in her early to mid 30s will typically come to see me. There's a lot of sort of bias around who are the people who come to freeze their eggs. Lots of people think that the women who are freezing their eggs are these sort of type A career women, and this was their plan all along. They're not intending to have children. They just want to, freeze their eggs. And that's actually a very tiny percentage of the women that I see. And this has been seen in other studies where they've surveyed women who are freezing their eggs. The vast majority of women who want to come to freeze their eggs are not coming as a plan A. This is very much plan B, C, D, right? It's women who otherwise would have loved to have a family, but don't have the partner with whom to start that family right now.
Yep.
So to be honest, it's interesting because it's allowed me to approach my patients in such a different way, because I understand that the women who are coming to see me, this is not like, I'm so excited to be here. It's like, this is the worst. They're so not excited to be in my office. They're coming to me very much from a place of vulnerability. I like to joke with my patients that I often make people cry. Like, I keep tissues in my office all the time. See?
Yep.
Because it's a hard thing to talk about, but the goal is really to start off with a good informed conversation. So at Extend Fertility, and this is going to vary depending on where you go and who you see, but the way we like to do it is we have our patients come in for some assessment first. So we do blood work and an ultrasound first before they meet with anybody. They get a phone call, and we have very nice staff here, but before they meet with the doctor, we do the blood work and ultrasound so that we have some information to share with them when we have our conversation. The things that we look at are a hormone level called AMH, or anti-Mullerian hormone. It's by no means a perfect test, and it's not really good at telling us, who's going to be able to conceive and who's not going to be able to conceive. And there's a lot of limitations, but it is the best tool that we have to help predict how many eggs somebody could make in their egg freezing cycle or freeze. So we do that, and we do an ultrasound where we look, like I said, at the follicles of the ovaries, and make sure there's not anything else on the ultrasound that would be concerning that could somehow impair the process. And then they meet with me or one of the physicians here. And really the goal of that conversation is to be able to address some of the background, some of the discussions we talked about here, like how does egg freezing work and why do we do it? To talk about how, what the results mean, what they mean somebody could expect from the process, right? There's such a wide variation in the way that women will respond to the egg freezing process, because there's a really wide variation in the egg supply of women at any given age, right? So it's kind of like height. There's some women, some kids grow to be tall and others grow to be short, and there isn't really much that we can do to adjust that. So we're all born with a certain number of eggs, but it's a different number of eggs for everybody, and we lose our eggs at different speeds. And so at any given age, you're going to have some women who can only freeze 2 to 3 eggs in an egg freezing cycle, and you're going to have other women who are going to get like 15 to 20 eggs in their egg freezing cycle. Right. And so to be able to arm somebody with an understanding of where do they fall on that spectrum, what's a realistic expectation, what are the realistic things that frozen eggs can do, what can't they do, it's a long conversation, and we talk about individual reproductive goals and all of that. So that's the big piece of it. And many women will decide at that point to move forward, and others will table it for some period of time based on the conversation. And, others may say, okay, this is not something for me. For those who decide they want to move forward, the process is about a 2-week process. We typically start with the beginning of the period. And we have patients come in for blood work and ultrasound, make sure everything looks good. We start medications, usually in that evening. The medications are hormonal injections, so that tends to be a big hurdle for some women, but I hope, do a good job of training our patients to be able to self-administer them. And they take the medications anywhere from 8 to 12 days. We have monitoring visits. So really, like I said, it's so individualized, and women are going to respond in different ways. And the goal is, based on your response, to adjust and individualize the protocol so that we're really maximizing how many eggs somebody's going to get from their egg freezing cycle. And then when they're ready, we do an egg retrieval, which is a very minor procedure where we remove the eggs from the ovaries. It is done under anesthesia. So same kind of anesthesia someone might have for a colonoscopy or an endoscopy. Procedure only takes about 15 minutes to do. We use a transvaginal ultrasound probe and a needle through the vaginal wall. So there's no incisions, there's no stitches. And then we allow the eggs to mature in the lab for some period of time. The egg's maturity is a physical characteristic that the egg has to develop in order to fertilize one day. So we let them mature, and then we freeze the mature eggs, and then we tell the patients the next morning how many eggs were frozen. And then usually what I will do is have a follow-up call with my patients and go over, okay, this is how many eggs were frozen based on your age and what we can learn about your egg quality. So I guess I should have mentioned this. This challenge with all of this is that we can't test the quality of eggs at the egg stage, because an egg is just a single cell. And so if you were to look at the DNA or take the DNA out of that cell, you basically destroyed it. And so we make all these assumptions and all these calculations based on age and what we predict, how many eggs we predict might be chromosomally normal based on age. And that's where there's all this games of like, the more eggs you have, the higher your chances, because each egg is kind of like a raffle ticket. The more you have.
But we can't, I see a question here.
Yeah.
We can't freeze immature eggs, correct?
So you technically can freeze immature. It's not that the eggs can't be frozen, but right now we don't have good, reliable ways of fertilizing immature eggs. And so generally, unless there are extenuating circumstances, it's unfair almost to freeze immature eggs, because those are eggs that really we don't have an opportunity to use. So when we counsel patients and we say, okay, you have 12 eggs frozen, and that means you have this % chance of having a baby later on, that's really only holds true if the eggs that you have are mature.
Okay. And then talk to me when you're waking up from the actual procedure of removing the eggs, what does that feel like?
So for anyone who's had kind of, we call sedation, whether for like a dental procedure or, like I said, endoscopy or colonoscopy, you wake up kind of groggy. I mean, we have a full service procedure suite in our office that's actually attached to our embryology lab. So we can just off the tubes as we do the retrieval, we hand them off to the embryologist. But yeah, we have a recovery area. You wake up a little bit groggy. Sometimes patients are a little disoriented, but the medication that we use for anesthesia wears off really quick. Sometimes it makes people a little emotional. So sometimes people will be very tearful and they're like, I don't know why. But we're used to it, and it wears off pretty quick. So usually within 30 to 40 minutes, most of my patients will feel like ready to get up and go home. I used to tell people you'd be like ready to go to work the next day, but nobody goes to work anymore.
Nope. Because I remember some pain afterwards. Is that normal?
There certainly can be cramping and bloating and some discomfort. I mean, I'm pretty, we try to get on top of the pain before someone leaves our office. So we'll give them some medicine in the procedure itself. We give people oral medication before they leave their office, so they should be pretty well sort of tanked up before they go. It is not going to be pain-free, but there's, it should be menstrual cramps or better.
Got it.
By the time they leave. And like I said, most of my patients by that evening or the following morning are feeling sort of ready to go back to their lives. There's always going to be a wide range, right? Just like there's, every woman is different. So there's going to be some women who are like jumping out of their chair and ready to go, back to the gym. And there are others which it's going to take, a week till they feel really back to their normal selves. Everything that happens as a result of the stimulation. So, the ovaries grow, that makes people feel full and bloating, and your estrogen levels go up. So that causes breast tenderness and vaginal discharge and moodiness and fatigue because your body's working extra hard. And all of those things shouldn't be debilitating. First of all, you should be able to go about your regular daily life doing this process, and they should all typically resolve within a few days to a week after the procedure.
Helpful.
One of the interesting things that I've come to appreciate by looking at my patients who do egg freezing is different from my patients who are doing IVF. And they really truly are inherently a different group of women. And actually, one of the papers I recently published is about this particular point, is that we utilize the trigger medication. So the trigger medication is a medication that we give at the end of the stimulation in order to start the maturity process for the eggs. There's two different types of trigger medication, and I don't want to get into the nitty-gritty details of it, but one of them actually allows the hormone levels to come sort of crashing down back to baseline very, very quickly. And that isn't always the sort of first choice for women who are doing IVF, because you actually need some of those hormones to sustain a pregnancy. But for somebody who's doing egg freezing, that's actually extraordinarily beneficial, right? If 2-3 days later your body is back to normal and you can go back to your regular life, that's extraordinarily beneficial. And so we do almost exclusively use that trigger because it's decreases the risk of things like hyperstimulation syndrome, which are rare but can happen. But it also allows us to really give people back their, do this process and then kind of go back to their regular life with very little sort of residual feelings, and not compromise their maturity or outcomes.
And that's helpful. And I know you spoke a little bit about the likelihood that it's going to work. We do have a question here about, should you get fewer eggs, 3 or 4 fewer eggs versus a woman who's getting 10 to 12 eggs per cycle? Is there more of a chance in the if you get more that it's going to work versus fewer?
That's a good question. So, I mean, egg quality, which again is really the determining factor of if any one egg is going to go on to produce a healthy baby, is binary. Like, the eggs are either normal, they have the right number of chromosomes, or they are abnormal, they have the wrong number of chromosomes. And that process is really sort of tied to age. So, and even though egg supply, which is what really drives how many eggs can be produced, even though that's tied to age too, they don't always run in parallel. So if you have a young woman, let's say a 28-year-old who has, for whatever reason, a very low egg supply, she may only get a few eggs, but those eggs are much more likely to be successful than on each individual egg than somebody who's 38 who has a higher egg supply, right? And so what I tell patients is that, if you have 20 eggs, let's say, your chances of success with those 20 eggs are just as good whether you got that in 1 cycle or it took you 5 cycles to get there. Now, obviously, the person who took on 5 cycles, there's a huge investment of, finances and resources and personal time and effort that goes into it. But the outcome is the same. Either the eggs are going to be able to or not. And the truth is, no matter how many eggs you freeze, there's never a guarantee. There's always a possibility that none of them will work. Especially once you thaw and start fertilizing the eggs, there's all these other variables, right? Like the sperm matters, the uterus, the pregnancy. There's so many other things that go into place. So it all has to start with a good egg.
Right.
First piece. But then there's a lot of variables that come in thereafter. So, and that's all part of the discussion that we have, is really to be able to kind of put that into perspective. What can it do? What can't it do? Yeah.
Fair. Okay, we have another question. I haven't met my significant other yet. I'm 28 years old. I think I'm fertile. Should I be freezing my eggs now or wait a few years? Maybe I'll meet him. Maybe I can conceive naturally. I'm so nervous, but I don't want to miss the boat.
So sweet. So yeah, I mean, this is essentially this is the conversation I'm having 5, 6, 7 times a day, in various ways, shapes, or forms. And the problem is, well, there's 2 things. One, this woman, like many of us, doesn't know if she's fertile or not, right? She never tried to conceive, and she doesn't know, am I fertile or is there a problem? And so that's the first piece, is that, the assessment, the testing can give us one view into somebody who, can you be reassured, or, are my concerned? The sad thing is that, as much as a field, we have advanced over the last few decades, where we can, millions of babies have been born from fertility treatments that never would have been able to be born in prior generations. But we still, our knowledge about what happens before someone receives an infertility diagnosis, right? You don't wake up one morning and you're infertile, right? This is a process that's happened over time, but we have very little knowledge over that process, very little testing, or we don't really have a way of saying, okay, based on these tests, you have a 90% chance of having a baby in the next 5 years. I wish we had that. But we don't. So one of the things is having conversation with a physician who understands the the factors at play, understands, I can give somebody an AMH and I can help them understand what their egg supply is like. And maybe somebody who has a really low AMH, it may not affect their fertility in the short term, but if they're gonna be a few years out from conceiving, we don't know what's going to happen in the future, those kinds of things.
Right.
If it's on your mind, it's worth discussing, right? Even if you have a conversation with somebody and you decide, okay, this isn't something I need to do right now, or I'm going to table it for a few years, or I'm going to revisit it in 6 months, the knowledge is just as valuable. So that's
Thank you.
what I recommend.
Okay, another question. This is what everybody wants to know. The cost. Talk to us about the cost.
So this is going to vary drastically based on geographic location, where you are, and what practice you're seeing. One of the things that we thought about when we started Extend Fertility was recognizing that in order to really make egg freezing as accessible as it can possibly be to a larger group of women, that you have to try to do it at a lower cost point. And so we've tried to bring the cost point down, and I think that's also trickled to other places. So the cost has down, but it's still a really significant cost. So you're still talking about probably somewhere between $8,000 and $10,000 if you include medications. Sometimes it could be more depending on where you are, but I think at minimum, with medications and storage, you're looking at probably somewhere between $8,000 to $10,000 for a cycle. I think that's a big investment.
Is that storage yearly included, or how does that work?
It depends. Everyone's got a different kind of way they do storage. So here we do we have, like you could pay annually, you could pay for 5 years, you can pay for 10 years. It's like a few $100s a year, depending, if you have a storage. We use a long-term storage facility that's outside of New York City. So that allows us to have sort of a lower price point. But if your storage facility is in Midtown Manhattan, for example,
prime real estate
is higher. So there are a lot of different factors, and I think one of the important pieces is to become well versed in that when you speak to your, when you go for your visit, to really ask them, what are the costs? Are there other fees that are associated with it? We try to lump it together, but some places will split it apart. The anesthesia fee is another fee, and the medications usually come from a pharmacy. So there's a lot of moving pieces here. And it's good to have to be transparent about that and kind of get all of that up front. There are options for financing and monthly payment, depending on where you go and what you have available to you.
Right.
There are some of those that make it a little more tolerable and achievable. And then more and more, we're seeing places where there are insurance coverage that may help. So it's always worth looking into. Our insurance programs that will cover just medication. So even that's going to be a significant contribution. There are companies that work with fertility organizations that provide coverage. So things like Progeny and Win Fertility, those are corporate benefits that people may have. They may not even know they have them.
Right.
They will cover the process. You don't have to necessarily have a super great health insurance program. It just depends on like the random, like each kind of policy is going to have different things associated with it. That's a little bit different than women who are freezing their eggs for a medical reason. So, egg freezing kind of started as a way to help young women who were undergoing chemotherapy preserve some fertility, because chemotherapy had a high rate of putting people into early menopause. In New York and in several other states now, there's a state mandate that kind of egg freezing needs to be covered. And there's also a lot of charitable organizations that are around to help women who are in that circumstance where it's like an urgent medical need. So that's a little bit different.
Correct. And I don't know any organizations right now that are covering egg freezing costs for women without cancer, unfortunately.
No, there are some that have, have assistance in a variety of different forms, but straight up like that, unfortunately not.
We do get calls like that a lot.
Yeah.
Okay, my last question for you, and feel free to also chime in. We get this question a lot from intended grandparents. how the heck do I talk to my 30-something-year-old daughter who is not married? She's so focused on her career. I know she should be freezing her eggs. How can I talk to her in a sensitive manner? Do you have any advice for that?
Yeah, so I will say, even if your daughter hasn't brought it up, I'm going to be nearly certain she's thought about it. This is what women are talking about. It's, when I started in this practice, it was just a few years ago, constantly my patients were telling me, I don't know anybody who's done this. I'm not telling any of my friends. This is not something I want to be public. And really, within 6 months to a year, the conversations have just shifted. All of my friends are doing this. We're all talking about it. It's on people's minds. It's so much more, it's less taboo. It's being discussed. So, for parents who think that their 30-year-old daughter hasn't thought about it or hasn't thought about her fertility or having a child, she almost certainly has. And again, even if she's super focused on her career, the vast majority of women who are in careers are not in careers to the exclusion of having family. Like, they would like to have a family, but it's more the partner piece that's in it. And so, most of those women are going to be open to the thought. I mean, it might be uncomfortable for them to have that conversation with their parents. If the parents are in a position where they can have some financial assistance, that might be a more welcome conversation.
Yeah.
I've had patients who have told me, like, this is more important to me than having a big fancy wedding. And I went to my parents and said, I want to dip into whatever money you're saving for my wedding. I'd rather do this. Now, that's not everybody, and I'm not necessarily advocating for that, but I'm saying, like, that's, those are some of the conversations that might be, that you could have. But it goes back to the education piece, that this is not something that we grow up thinking about, that we grow up talking about. We're not educating our high school and college aged women about, what happens to fertility, how do we get pregnant, what happens when people can't get pregnant. Like, those are things that aren't really being talked about regularly. I've actually been invited and spoken to high school aged girls several times, and I've actually been collaborating with some people on the ideas for how we can kind of help educate our young women as they grow up. So it is. And I think that starts at home too. Like, if you can have conversations with your children about all these things, right? We try to encourage parents to have children, conversations with their children about puberty. It's the same, it's just a continuum.
Yep.
I know you were saying that in your house, it's like a very open discussion. Mine is very
Yes. I remember my now almost 9-year-old talking to his 2-year-old class about petri dishes, and it was on Mother's Day. He wrote me this whole story about, like, sperm and petri dishes, and we're very, very open in our family. But the truth is like, my family growing up, we were open about things, but, like, infertility was never on the table. I mean, and I literally, when I was going through it now almost 12 years ago, I literally thought I was the only one in the world going through infertility. And now, thankfully, we're speaking about it more and being, much more open, but still it's important to, I like what you're doing around education in the schools, and it's very, very important.
It's the same thing. Thankfully, now you're right. We're not in a position where people are like, I'm the only one going through infertility. I think the taboo, the discussion, the stigma around it is declining. I think we have a lot of work to do in many of our communities as well. And I think in our communities, the role, the discussions among single women, it's changing, right? So I don't typically get a lot of women who are like, I must be the only one doing this.
Right.
But I've said this in the past, I think single women in Jewish communities, particularly in Orthodox Jewish communities, but really in any Jewish community, are like really on the margins. We're really not doing great as a community. We're not doing a great job of inclusivity of single women, and probably single men too. Although, when there was synagogue services, it's a little more, there's a pathway there, but these women are very disenfranchised and feel very excluded from our communities, sometimes with good reason. So it's the conversations, communal conversations. And one of the things, I lecture in communities, and before COVID, I was like traveling. In March, I was supposed to speak in Cleveland, and I had to cancel my trip.
Yeah.
One of the things I'm really passionate about, and I do when I do these like lecture series, is engaging communities around discussion. So some of the things that you do too, right? Like the talk that you're having tomorrow, we can segue to that. But
Sure.
part is engaging communities and discussing things that are not straightforward, that are not
Single
simple.
moms by choice. We're seeing a huge influx, and in the Orthodox community, I can't really talk about it. It's really interesting.
Yeah. The more we engage our communities in talking about these issues, whether it's IVF, whether it's third-party reproduction, recurrent pregnancy loss, egg freezing, all of these sensitive, intimate discussions, the more we engage community members in talking about them, even if those individual community members will never experience it or never need to utilize those services, just the more we normalize it, and the more that those people who need those services or want to utilize them have the opportunity without feeling stigmatized and excluded from their communities.
Amen. Dr. Maslow, this was awesome. Thank you so much for being just so open. I do want to go back. Tomorrow night, we are going to be having our next Insta Live. Not that we do these every single day, but we are going to be speaking with men, with couples tomorrow night. Real men, real stories. 2 couples, actually also from New York, will be discussing their fertility journeys from the male perspective. So this is male infertility is not something we speak about often. I could never get my husband on one of these calls, but maybe he'll join us tomorrow night. Also, I want to wish you a very happy birthday, early birthday tomorrow. And this was awesome. For those of you who are not able to see the whole thing or you want to pass it along, we will be recording this and posting this on our Instagram sites as well as our website. Follow Jewish Fertility Foundation and keep in touch. Thank you so much. Have a great day.
Great day. Take care, everyone. Thanks.